So when we prepare
Good evening to everyone and welcome to today's session. Can you able to see clearly? Amrita Francis, India Observer and many more. Sorry, we have hosted a live event but could not be able to stream on the live event. Yeah. Ranjit Shah and many more. Hope everyone, 1 minute, everyone could be able to come back to this location. Yeah, very good. Kavya and many more. Good, good. Is the voice loud and clear for everybody without any interruption? Yeah. So once more, we are back to the um, anatomy. And very nice to see Jitendra, Madhu, and everyone who are all online. Today we are going to finish about 100 MCQs, covering a good number of topics. So be well prepared for a little long session, right? Yeah. So we have done major topics like arteries, branchial arch derivatives, facial nerve, trigeminal nerve, and few more important topics. Now let's continue our discussion with some of the minor topics. Pharynx. Nasopharynx. What does it basically contain? Nasopharynx. Nasopharynx has pharyngeal recess, pharyngeal tonsil, and salpingopharyngeal fold is what you have to basically remember. So, if you look at the structure, this is the soft palate. This area is called nasopharynx. You have the oropharynx, and then you have the laryngopharynx. So this is all the tongue, and this is the soft palate. So soft palate is the one, the uvula is the one which, if it moves backwards, it can be able to seal the nasopharynx from the oropharynx. Similarly, you have the epiglottis. If epiglottis happens to move back, it can be able to seal the laryngopharynx. So that is what you have to basically remember. The fundamental anatomical orientation. Then we have the palatine tonsil, and this is called the palatoglossal arch. Palatoglossal arch. So in a close relationship to that, the posterior 1/3 of the tongue is located. So between palatopharyngeal arch and the palatoglossal arch, you are having the palatine tonsil. Then the auditory tube, the eustachian tube. And when the eustachian tube, which is connecting the ear with the mouth, you have the salpingopharyngeal fold, which is located over here. And you can also see that the laryngopharynx, the oropharynx, and the nasopharynx are like a continuum, is what you should remember. Now, what is salpingopharyngeal fold? When the eustachian tube is the one which is connecting the mouth and the ear, right? So, the posterior margin of this eustachian tube, there is an elevation which is called the salpingopharyngeal fold, is what you should remember. Now, when we talk about the nasopharynx, yes, Madhu is proposing something. Sir, I have a request. If all students agree, give a daily assignment and evaluate us by making us to do the video seminars like we used to do in the undergraduation. Studying alone is very monotonous. A very good thought, actually. Always when you get a chance to share, say about 10 or 20 questions for discussion with the other students, it will be a wonderful opportunity. So this thought is there in my mind since a long period of time. But I was always skeptic. How many students volunteer to come forward to pick up around 15-20 questions and initiate a discussion? So that was the only thing I was skeptic about. But it doesn't matter. If some of the students can actually come forward to initiate create 20-30 questions on a topic and initiate a live stream, we can do it on our channel, and the other students can participate by contributing the answers, and we can create a live video group discussion also. We will try to take it forward in a short period of time. Yeah, a very good thought, Madhu. So, the nasopharynx is 4 centimeters high, 4 centimeters wide, 3 centimeters in length, between 3 to 4. And the body of the sphenoid and the first 2 cervical vertebrae form the roof and the posterior wall. And the lateral wall of the nasopharynx is the place where the eustachian tube will be making an opening, is what you need to remember. And along the lateral wall of the nasopharynx, you have a very important structure called fossa of Rosenmuller. Why this is important? Fossa of Rosenmuller. When the nasopharyngeal carcinoma, the malignancy of the nasopharynx, it typically starts at the fossa of Rosenmuller, is the earliest site. That is the reason we need to basically remember, right? Now, what is the weakest part of the pharynx is my question to all of you. Keep punching your answers, doctor. That way, we are all more or less interactive for us to have the discussion. In fact, I got one more thought. See, we take 1 hour to solve 30 questions, right? We take around 30 questions, maximum 1 hour. So before we start the discussion, we give these 30 questions as a quiz, what we are going to discuss. You quickly apply your thought. Every half minute you solve, 15 minutes time we will give. You solve the 30 questions, let them go wrong. wrong or right doesn't matter. After that 15 minutes, we will start the class and have a discussion for 1 hour. After that, once more, the next 30 questions is being released to you as a quiz. I'll give you a link. You click on the link and can be able to solve it on your on your own smartphone. Then once more we have a discussion of 30 questions. So that what happens is, instead of being passive attendees, you will be in a position to be an active attendee. That makes a huge difference. So please let me know if you all feel that way it is good. Then every 1 hour के बाद हम 15 minutes break लेके 15 minutes में quiz solve करके फिर एक 1 hour में 30 questions solve करेंगे. I mean discuss करेंगे. How will be the idea? Yeah, that's a good way, right? Karan Patel is also agreeing for that concept. Like that, entire day we can be able to study. 15 minutes, 30 questions, 1 hour discussion. 15 minutes, 30 questions, 1 hour discussion. Entire day also we can be able to have a long day marathon session instead of being passive listener, right? So that's the plan. Let's try to do that from tomorrow onwards. That's right. Now, doc, it is the between Thyropharyngeus, Cricopharyngeus, you have the weakest part of the pharynx, which is called as Killian's dehiscence, is what you need to remember. Now let's look. This is the Thyropharyngeus. Here you have the Cricopharyngeus. Between the two, you are having the Killian's dehiscence. Then this is the longitudinal muscle of the esophagus, and here you have Lymer's dehiscence. So two weak points you have to basically identify. So this is Thyropharyngeus muscle classically. This is the Cricopharyngeus. Between the two, what do you have? The weakest point, which is called Killian's dehiscence. Sometimes there can be a herniation through that which can occur, which is called as pharyngeal diverticulum, is what you have to remember. What is the main motor nerve supply of the pharynx? Major motor supply. You should remember it is the vagus nerve. If you look at the pharynx, all the muscles of the pharynx are supplied by the vagus through pharyngeal plexus. Vagus through pharyngeal plexus. The only muscle of the pharynx which is not supplied by the vagus but by the Glossopharyngeal. Which one? Stylopharyngeus. Like a parrot, you should answer it in the tomorrow's exam, doctor, because last 20 years I have been seeing postgraduate entrance exam. This is one of the most standard questions in the world. One more standard question, batao. All muscles of the face, motor supplies by the facial nerve, except levator palpebrae superioris that elevates our eyelid. It is supplied by the oculomotor nerve, is what you have to basically remember, right? Now, if you look at the pharynx, the motor and sensory innervation, right? The motor and the most sensory innervation comes from vagus and glossopharyngeal. These two nerves form the plexus, and the pharyngeal branch of vagus, the branches from the external laryngeal nerve, from the superior laryngeal nerve, and the pharyngeal branch of the glossopharyngeal, they are the ones which are the main nerve supply, is what you need to remember. The second stage of the deglutition, what is it characterized by? Elevation of the larynx. अच्छा भाई, deglutition में कितने phases रहते? Deglutition is swallowing. Oral, pharyngeal, esophageal, right? And the total swallow time from the oral cavity to the stomach is generally not more than 20 seconds. And of course, if the mom prepares gajar halwa, it won't even be 20 seconds. Much earlier we will swallow it. Now, the process basically begins with the contraction of the tongue, and cerebellum controls this a lot. So the trigeminal, facial, 12th, that is the hypoglossal. These are the three nerves, 5th, 7th and 12th, hypoglossal. Hypoglossal supplies the motor supply to the tongue. These are the three nerves which are most important for the oral phase. अगर इस नर्व्स में कुछ दिक्कत हो गया तो then the oral phase become affected. Now, this is the tongue, and let's say the bolus of food is over here, and here we are talking about the pharynx. We have the epiglottis, and this is glottis. Obviously, the glottis, the area where the vocal cords are typically located. So, the upper esophageal contraction is a very important component in this initial phase, is what you need to remember. Then comes the pharyngeal. Pharyngeal is the shortest of all the phases, but the most complex phase. And main thing pharyngeal phase mein kya hota bole to, there is a closure of the nasopharynx. That is what you should remember. Now, when the pharyngeal phase is happening, the pharynx prepares to receive the bolus from the mouth. From the pharynx it goes to esophagus. That time kya hota? Auditory tube become opened, oropharynx become closed, laryngeal closure occur, hyoid will become elevated, and the bolus of the food will pass into the pharynx. So this is, the uvula has already sealed the nasopharynx, right? And the bolus of the food is traveling into the esophagus, and the upper esophageal sphincter is relaxed, unlike in the first phase, oral phase, where the upper esophageal sphincter is contracted. Then finally comes the esophageal phase, where the bolus of the food is propelled through the cricopharyngeus, around 25 centimeters, and it is at around 3 to 5 centimeters per second it is being pushed, and the lower esophageal sphincter relaxes and the food moves into the gastric cardia, is what you need to remember. So this is how the bolus has entered into the esophagus and moving towards the stomach, is what you have to remember. So these are the circular muscles which contract, enabling the bolus of the food to enter, and the food passes from the pharynx into the esophagus and ultimately into the stomach, is what you need to remember. So now, doctor, the stage of the deglutition, which is voluntary in nature, out of all these phases, it is the first stage. जब लड्डू मुंह के अंदर जाता है, जब oral phase होता है, oral phase is considered to be a voluntary phase. So what are the cranial nerves important for that phase? 5th, 7th and 12th. These are the three nerves which are very important. Now, with regard to the pharynx, what are the important statements about the pharynx? The auditory tube opening, it is located along the lateral wall of the nasopharynx. The soft palate is at the level of the separation of nasopharynx and oropharynx. You all agree with me? And where does pharynx meet the esophagus? Pharynx meet the esophagus. What is the anatomical level? Lot of times this question was asked. The golden number is 6th cervical vertebrae. Is the location where typically you have the pharyngo-esophageal junction, anatomical level, is the sixth cervical vertebrae is what you are going to remember. Excellent. I am so happy to see 50 online students across the country. Great. Wonderful. Now, what is the wrong statement about this? Yeah. The gag reflex. 10th cranial nerve is the efferent and 9th cranial nerve is the afferent. That is what you need to remember. Now, fatafat bolo doctor. What are the various reflexes? What are their afferent limbs and efferent? You should be very sure about. Corneal reflex when you touch with a wisp of cotton. Ophthalmic nerve. Ophthalmic nerve. Ophthalmic nerve is a division of trigeminal, right? That is the afferent, and facial nerve is the efferent that closes your eyelid. Jaw jerk, when you do jaw jerk. It is the mandibular nerve which is both afferent and also efferent is what you need to remember. Then gag reflex. Glossopharyngeal is afferent, which takes the sensory, and the vagal is efferent. That's what examiner want to be very sure about, right? Then carotid sinus. Carotid sinus. Glossopharyngeal is the afferent and vagal is the efferent for the carotid sinus. Then pupillary reflex, when you throw the light, optic nerve carries. So it is the afferent. And oculomotor nerve carries parasympathomimetic fibers to sphincter pupillae and lead to pupillary constriction. That's the reason. Third is the efferent. Efferent for the pupillary light reflex, whereas optic nerve is afferent, is what you have to basically remember. India Observer rightly says it is monosynaptic or polysynaptic. The jaw jerk. Good question. So fundamentally, if there is a reporting happening to the spinal cord or the motor nuclei in the brainstem, एक ही होता है. Only thing is, for cranial nerves, motor nuclei are in the brainstem. For the peripheral nerves, the motor nuclei are all located within the spinal cord. Now, for the lacrimation, why do you get tears? When some dust touches your eyes, right? And ophthalmic nerve is the afferent, and facial nerve is the efferent, because it provides the secretomotor fibers to lacrimal gland to undergo lacrimation, is what we have already discussed in a great detail. So those who have missed our earlier classes, doctor, kindly go back to the online mbbs.com video library, and in the anatomy, all these sessions are all archived, right? Now, gag reflex. Elevation of the soft palate to seal the nasopharynx. That is the most important component of gag reflex. Also, during gag reflex, there is a closure of the glottis to prevent the airway, trachea. And there is a constriction of the pharynx. So these are the three things that happen in the gag reflex. Glossopharyngeal is the afferent. Vagus, because most of the pharyngeal muscles are all supplied by the vagus. Glossopharyngeal is the one which is carrying your sensory touch in the posterior one-third of the tongue. So that is the reason it is the afferent for the gag reflex is what you need to remember. So glossopharyngeal is afferent and 10th cranial nerve. Vagus is the efferent for the gag reflex. Ask the patient to swallow or ask the patient to say ah, and you look for the elevation of the palate and you see whether uvula is not going asymmetrically. That is very important to check. Then accessory nerve, if you want to check, ask the patient to shrug the shoulders against resistance. so that you are checking for the trapezius. Or you ask him to turn the head against resistance, then you are checking for sternocleidomastoid. These two are basically supplied by the accessory nerve, is what you have to ultimately remember. Now, doctor, which laryngeal cartilage is above the glottis is a very important question. So you should remember it is the epiglottis which is above the level of the glottis is what you need to remember. So doc, this is the sphenoid sinus. This is the entry of the auditory tube into the nasopharynx, and this is the oropharynx, this is the laryngopharynx, and this is the trachea. And epiglottis is the one which is sealing. It is a gatekeeper for this glottic area so that the food does not enter into it. Then here you have the frontal sinus, superior, middle, inferior nasal concave, and you have the hard palate, and this is the soft palate, and this is the oral cavity and the tongue. And there is a need for a clarity on this important imaging, doctor. I am not saying you don't know, you know that very well, but sometimes छोटे छोटे चीज़ों में हमको बड़े बड़े confusion निकलेगा unless we have that clear three-dimensional anatomical outlook towards the things. Once more, this is the epiglottis, and these are the vocal cords. And above the vocal cords you call supraglottis, below that is subglottis, and at the level of the vocal cords you call it as the glottis, as all of you know very well. So when the food is entering, it should go सीधा इस तरफ जाना है. So इसके लिए glottis उसको close करना है. So that is very important to remember. So you can also see this is how the epiglottis you can be able to look at it. So while you are doing the endotracheal intubation, with the tip of the endotracheal tube, if you can slightly elevate this epiglottis, no, you can see the vocal cords. You can see the tracheal rings basically, and you have to pass the endotracheal tube. Simple. Open the mouth, uvula you can see, below that you can see the epiglottis. Just with the tip of the endotracheal, with the tip of the ET, you have to elevate it and then pass the endotracheal tube is what you need to remember. Now, what is the narrowest part of the gastrointestinal tract? Pharyngoesophageal junction is considered to be the narrowest part. So basically, pharynx in general is a conical fibromuscular tube. Conical in shape. Cone. Ice cream cone, right? It's a conical tube. What is the length of the pharynx? 12 to 14 centimeters. From where to where you call it as pharynx? From the base of the skull to the lower border of the cricoid cartilage, you call it as a pharynx. The width of the pharynx is 3.5. But where the pharynx meets the esophagus, that's called pharyngoesophageal junction जो होता है ना doctor, right? That is the narrowest part. अगर हम वर्टिब्रे लेवल पे ले लिए तो ये narrowest part कहाँ होता है? अभी पढ़ा है हम C6, sixth cervical vertebrae level में आपको you will find this narrowest part, which is the pharyngoesophageal junction, is what you have to remember. With regard to the middle constrictor muscle, what is wrong about it? Typically, it lies on the superior constrictor, middle, and the lymphatics of it drain into the deep cervical lymph nodes. And you all know very well that esophagus sensory innervation comes from the vagus. But the esophageal muscles, from which pharyngeal pouch are they derived, is a very important question. So you can remember that the middle constrictor, what are its attachments? The middle constrictor is attached to the stylohyoid ligament, and the lesser cornu of the hyoid bone, and the upper surface of the greater horn of the hyoid, and basically it will be fanning out towards the posterior aspect, and all these constrictors, doctor, superior, middle, inferior, all of them posteriorly, they will get merged into what is called as pharyngeal raphe. Pharyngeal raphe is what you need to remember. And the posterior part of the middle constrictor overlaps with that of the superior constrictor is what you have to remember. So once more, this is another outlook. You can see this is the superior constrictor, this is the middle constrictor, this is the inferior constrictor. And you can also see there is a palatopharyngeal sphincter. Palatopharyngeal sphincter on the deep surface of the superior constrictor. So pharynx also at its opening, at the starting point, it has got a sphincteric action is what you have to remember. Now, these are not the derivatives of the second arch as given in the question. They are all the derivatives of the fourth arch. Once more, doctor, from the fourth arch, what are all the derivatives? Favorite question of the examiner. Thyroid cartilage niklega, fourth arch derivative. Cricothyroid, constrictors of the pharynx, palatopharyngeus, levator vellae pilati, uvular muscles of the soft palate, palatoglossus of the tongue, and the vagus is the one which is basically supplying is what you need to remember. And the vagus, how does it supply to all these muscles? Through the superior laryngeal nerve. Superior laryngeal nerve ka two branches hai. What are they? External, which is motor, internal, which is basically sensory. The other day we discussed in the superior laryngeals, external is motor. All muscles of the larynx are supplied by the recurrent laryngeal nerve. The only one which is supplied by the superior laryngeal branch of the vagus is cricothyroid. The other day we have discussed it emphatically. And the fourth arch ka blood supply comes from the arch of aorta on the left side, and right subclavian and brachiocephalic artery on the right side is what you have to ultimately remember. So, the muscle which is being spared during injury to the cranial root of the accessory nerve is which one? So, Stylopharyngeus is the one, because Stylopharyngeus is supplied by Glossopharyngeal nerve. Glossopharyngeal nerve is what you need to remember. So, Stylopharyngeus ka kya hai story? It originates from the styloid process. Styloid process. Very good. Good to see Arshad Musa, Tapash Paul, Ranjit, and Satya, many more who are all online. So, from the styloid to the thyroid cartilage, this stylopharyngeus will be extending, and it is the one which is supplied by the glossopharyngeal nerve is what you have to remember. So, इसका function क्या होता है डॉक्टर? As stylopharyngeus contract हुए तो your pharynx get elevated when you are speaking, when you are swallowing, right? Swallowing and speaking, then stylopharyngeus is the muscle which is elevating your pharynx is what you need to remember. So, I have grown up in a small village with my grandmother. She used to be very strict disciplinarian. She used to say, we all used to sit on the floor, and a typical Telugu Brahmin family. So, she used to, while serving food, she used to be very strict. No talking while eating, and no laughing while eating. She is very kind-hearted grandma. I enjoyed my childhood. So she used to say, if there is a high chance of aspiration, and you will go to the heavens straight away. So after becoming a medical student, I learned that elevation of the pharynx is the function of Stylopharyngeus. Swallowing and speaking are very closely related to each other. And pharynx esophagus is very close to the larynx. So that is the reason you have to be very careful about the aspiration, doctor. Right? Now, which is a correct statement about all these story. All the constrictors of the pharynx, they are inserted into the median raphe on the posterior wall of the pharynx is what you need to remember. So typically, if you look at the constrictors, inferior constrictor overlaps the middle constrictor, doctor. Inferior overlaps the middle overlaps the superior, and all this will be fanning towards the posterior aspect, and all of them meet in the posterior aspect at the fibrous raphe is what you have to ultimately remember. Now, middle constrictor of the pharynx, it has an attachment to what? Such a repeatedly asked question. So, it is the body of the hyoid bone. Just before we have seen, no? Middle constrictor is that triangular muscle, and typically it is the hyoid to which it is very closely related, hyoid. That's the reason to the body of the hyoid bone it is attached. So you should remember each of these constrictors, what are their typical attachments. Superior constrictor, if you take the base of the skull and the pterygomandibular raphe, superior constrictor. Middle constrictor is attached to hyoid bone, and inferior constrictor is attached to thyroid and cricoid cartilage is what you have to basically remember. I am so happy today to see almost 56 online students quickly learning anatomy. Anatomy is one of the deadliest subject if you don't have a pictorial orientation. Pictorially, imagologically, it should go and sit in your mind. Then it is the easiest subject on the planet Earth. And that is most scoring in the PG, medical, PG, dental, any entrance you go, FMG or any exam. Anatomy very scoring, and only those who got a three-dimensional outlook towards it can only be able to answer very standard questions like gynecology, obstetrics. 100 out of 100 marks you can get it because questions are very standard. Now, which muscle is attached to the oblique line of the thyroid cartilage? Oblique line of thyroid cartilage. Inferior constrictor, thyrohyoid and sternothyroid, they're all attached to the oblique line of the thyroid cartilage is what you have to basically remember. So basically, thyroid cartilage has two laminae, doctor. There is a laryngeal prominence called Adam's apple, a superior thyroid notch, and typically there is on the outer surface of the lamina there is something called the oblique line. And this oblique line gives attachment to three important muscles you have to remember for the tomorrow's exam. Thyrohyoid, sternothyroid, inferior constrictor of the pharynx, they all basically make an attachment to the oblique line is what you are going to remember. Superior border gives attachment to what? Thyrohyoid membrane attaches to the superior border is what you need to remember. It seems that today we are going to touch 100 score. Almost reached 60 online students. Very happy to see you all. Now, the muscles which are spared by the complete transection of the cranial part of the accessory nerve. Already we discussed this. That is Stylopharyngeus, right? Now, and one important point about spinal accessory, please remember, doctor. Accessory nerve, the 11th cranial nerve, is the only cranial nerve which both enters and exits the skull. स्कल में एंटर होगा और स्कल से एग्जिट होगा, दोनों करने वाला एक ही क्रेनियल नर्व होता है, वो है द एक्सेसरी स्पाइनल एक्सेसरी नर्व is what you have to ultimately remember. Which of the muscle is attached to the posterior part of the pterygomandibular raphe is a very important question. Just before we have seen, superior constrictor is the one which is attached to the pterygomandibular raphe. So, अच्छा भाई, एक pterygomandibular raphe कहाँ रहता है, इसका importance क्या है, इसके बारे में बात करेंगे. देखिए जनाब, ये है the pterygomandibular raphe, and this is how posteriorly fanning is your superior constrictor muscle, and on the mandible you have what is called mylohyoid line is what you need to remember. So if you look the other way, you can see this is the superior constrictor muscle, and this is the pterygomandibular raphe, and this is the mylohyoid line, and typically the superior constrictor contraction lead to a posteriorly directed pull is what you need to remember. Then this pterygomandibular raphe, if you look at it, it is important for many muscles to come and attach to it. आगे एक buccinator है, पीछे एक superior constrictor है, दोनों के बीच में है pterygomandibular raphe is what you need to remember. So अभी आपको orientation आ गए ना, 3-dimensional orientation मिल जाना, right? So this is buccinator, and what you are able to see here is the typical superior constrictor of the pharynx, and the buccinator is attached to the maxilla. So this is what you should remember. So pterygomandibular raphe, it originates from the pterygoid humulus, right, and attaches to the distal end of the mylohyoid ridge. You have seen, no doctor, the mylohyoid ridge का posterior end जो है ना, वहाँ जाके attach होता है. Pterygomandibular raphe is what you need to remember, and it is also it need to be remembered because for the superior constrictor and for the buccinator, for both of them to attach, it is the one which is centrally the bridging force between these two muscles is what you need to understand. That completes our journey on the pharynx. The next favorite topic of the examiner is glossopharyngeal nerve. As I told you, there are totally 540 MCQs, hi doctor, which we are discussing, which fall into around 40 topics in anatomy, right? Already we finished 309 questions. हमारा टेस्ट मैच 5-day टेस्ट मैच में 309 खत्म किया पूरा डिस्कशन करके. Now by the time you finish this 540 MCQ discussion, 40 topics in anatomy from which most of the high yield areas are being covered, you will get a complete mastery of the essentials in nutshell for the forthcoming, whether it is postgraduate medical entrance or dental entrance or FMG. बात एक ही होता है. There are about 10 subjects which are common for both, right? And especially basic sciences, question banks are more or less similar, right? So Next 2 days or maximum 3 days में we will try to cover all the anatomy खत्म करेंगे. From next Monday onwards we will start pathology, right? So next Monday, Tuesday, Wednesday, Thursday. We will plan 4-hour session. Be prepared. 6 p.m. to 10 p.m. लगातार review करेंगे रोज. There are totally around 500 MCQs in pathology. We will try to finish the review of them in 4 days, right? Those students who have not yet enrolled for any of our courses, suppose you are only attending freely, so you can join only for this single subject crash course, which we will try to complete in about 16 to 20 hours. We will try to complete. So you can call our helpline and can enroll for only one single subject also. You are very much welcome, right? So, but till Sunday we will have a free open broadcast. But Monday, those four days, when we complete this crash course, we will try to have it in a private link. Only subscribed students get that private link, right? So we can't help it because we love to give free, but there should be some way by which you join at a most comfortable, affordable way, right? So that we can be able to run this sustainably for a long period of time. So now, doctor, glossopharyngeal nerve supplies what? Stylopharyngeus muscle is what you need to remember. So this already we discussed. Posterior 1/3 of the tongue is supplied by the glossopharyngeal nerve. So you can see tongue posterior 1/3 is mainly by the glossopharyngeal nerve. So few comments about glossopharyngeal, let us try to consolidate. The fibers of the glossopharyngeal come out of the medulla. Through the jugular foramen it comes out. Through which foramen? Jugular foramen. Glossopharyngeal is a mixed nerve. Motor and also sensory is what you need to remember. And the motor innervates the tongue and the pharynx and provides the fibers, secretomotor fibers, to which salivary gland is from the glossopharyngeal carotid. Already we discussed, no doctor? Sublingual, submandibular. ये दो salivary glands जो हैं, इसको secretomotor fibers, parasympathomimetic, comes through the facial nerve is what you need to remember. Now, the sensory fibers, that's right. Ritu rightly says, otic ganglion is the buzzword that you need to remember. The sensory fibers, they conduct the taste, and also glossopharyngeal is responsible for the sensory impulses coming from the tongue and the pharynx is what you should remember. So the glossopharyngeal leaves the jugular, and along with the internal jugular vein and the external carotid artery, it will be, they both are its batchmates in medical college. And typically it reaches the pharynx by passing between middle and inferior constrictor. They both are in a very close relationship with it. And it is also in a very close relationship, glossopharyngeal, with the hyoglossus muscle is what you need to remember. Now, if you look at the glossopharyngeal, how is it distributed? Palatine tonsil, mucous membrane in the fauces and the base of the tongue, and the mucous glands of the mouth. They are all the ones which are closely related to the glossopharyngeal sensory supply. Then what is the ganglia? You remember in relation to the glossopharyngeal nerve. Typically there is one superior ganglion, inferior ganglion. दो ganglia का याद रखना है. Superior ganglia has no branches. Inferior ganglia is the one which will be leaving the fibers. Inferior ganglion is whose ganglion? Inferior ganglion is the ganglion of the glossopharyngeal. It carries the fibers, ultimately supplying the pharynx, the soft palate, and the fauces. That's what you need to remember. So once more, to get a good clarity, you can see the glossopharyngeal nerve, the ganglia of it, and how the fibers are ultimately getting distributed to provide the sensory supply to the posterior one-third of the tongue. Now, glossopharyngeus is mainly motor to which muscle? Stylopharyngeus, the only laryngeal muscle, pharyngeal muscle, which is supplied by the glossopharyngeal nerve instead of vagus, is stylopharyngeus. Secretomotor fibers to the parotid gland, sensory to pharynx, tonsils, and posterior one-third of the tongue, and the taste fibers from the posterior one-third of the tongue, even taste from the posterior one-third of the tongue is through the glossopharyngeal, is what you have to remember. Now, doc, a 10-year-old boy was admitted to the hospital with a severely swollen palatine tonsils. Tonsillitis is there, earache is there, high fever is there. Now the question comes, tonsillar area में जब tonsillitis होता है, the sensory input of the tonsils is carried by whom? Without any doubt, you should answer glossopharyngeal nerve is the one that should come to your mind. The only pharyngeal muscle supplied by the glossopharyngeal. A repeatedly asked question. So, ऐसे questions को एग्जाम में हम एक्सपेक्ट करना और अटैक करना है. That is very important. So, it is stylopharyngeus. Tympanic plexus is formed by the tympanic branch of the glossopharyngeal. इसको क्या बोलते हैं? Jacobson's nerve. Jacobson's nerve is the name given for the tympanic branch of the ninth nerve, is what you need to basically remember. So this tympanic branch of the glossopharyngeal nerve, it basically passes to the tympanic plexus in the middle ear. And what does it basically supply? It provides all the sensory fibers of the tympanic plexus. It also carries the preganglionic parasympathetic fibers, and they leave through the lesser petrosal nerve and they reach the otic ganglion. We have discussed this many times. And there is also one carotid branch of glossopharyngeal. It is the carotid sinus and carotid body. Carotid sinus and carotid body. You all know what is the importance of carotid sinus in cardiovascular physiology, carotid reflex. Uska afferent jo hota hai, afferent, that is once more the glossopharyngeal. So, carotid sinus, carotid body, sensory afferents are carried by the glossopharyngeal. And the muscular branch is the one which supplies the stylopharyngeus, as all of you know very well. Now, doctor, otic ganglion, let us talk about it. Otic ganglion, it sends the postganglionic parasympathetic fibers to the auriculotemporal nerve, is what you need to remember. So this is like a god of the illustration that should go and sit in your mind for the tomorrow's exam. अच्छा भाई, pons में you have inferior salivatory nucleus. कहानी वहां से शुरू होता. We discussed all these things in a great detail in our earlier MCQs when we were discussing, but फिर भी ये इतना खास चीज होता है एनाटॉमी में, जितने बार भी आप रिवीजन करें, आपके फ्रेंड्स के साथ बैठ के एक पेन पेपर लेके उनको एक्सप्लेन करना शुरू करें. जैसे मधुश्री राइटली सेज, sir, give us a topic, we create a set of questions and we will have a group discussion, right? So that is how the preparation is supposed to be, most of the toppers, I have seen not hundreds, thousands of students becoming toppers in the last 20 years. You know what is one most characteristic feature of all these toppers? They read less. They are not very ambitious readers. Don't think reading more will make you topper. No, no, no. Read less. Read focused. They exactly know what examiner want. And they are all excellent teachers. Remember, they are the guys who made another 10 of their classmates. Every day, every opportunity comes, they used to teach them. And that is how they became better and better every day and became the toppers. So that is the reason, Doctor, preparation is not a solo game. Preparation is all about being in a group, chasing a dream, along with a great army of your own classmates and friends and batchmates, seniors, जो भी मिले, juniors, जो भी मिले, सुनने के लिए तैयार है तो पढ़ाई देने के लिए आप तैयार रहना. That is the only secret. Every day, teach one, learn one, and practice one. They are the three things you need to remember. So, doc, inferior salivatory nucleus, उसमें से निकलता है Glossopharyngeal nerve. Now, this passes to the jugular foramen. Then, from this comes the tympanic branch. This is called tympanic branch. It forms the tympanic plexus. Tympanic plexus से निकलेगा lesser petrosal nerve. Lesser petrosal nerve. So this lesser petrosal nerve and the mandibular nerve दोनों मिलेगा foramen ovale से निकलेगा. And they basically come and reach the Otic ganglion. Otic ganglion is what you should remember. And from the Otic ganglion also receives something else. Ganglion है ना, it should receive a lot of things. So one thing it receives is lesser petrosal nerve from the glossopharyngeal, mandibular nerve from through the foramen ovale, mandibular division of the fifth cranial nerve. Also basically mandibular nerve does not enter into it, but the auriculotemporal branch of the mandibular will pass through it. That's what you need to remember. Then this lesser petrosal nerve fibers, which are the secretomotor, parasympathomimetic fibers, are carried by this auriculotemporal nerve to the parotid gland. Meanwhile, superior cervical ganglion from the T1 spinal segment will also send the sympathetic fibers. A sub otic ganglions may milke, they will go to the parotid gland, is what you have to ultimately remember. So this is the frequently asked question, doctor. You have to be 100% sure. The preganglionic parasympathetic fibers of the otic ganglion कहाँ से आएगा? हंसते हंसते खेलते खेलते आप आंसर करेगा glossopharyngeal nerve. Glossopharyngeal nerve. The gag reflex is lost if there is any paralysis of the ninth nerve, which forms the afferent of the gag reflex. Then glossopharyngeal supplies which muscle? Stylopharyngeus. Preganglionic parasympathetic fibers of the otic ganglion, AIMS का MCQ है. They come to lesser petrosal nerve, is what you have to remember. Whereas greater petrosal nerve, nerve of pterygoid, facial nerve, oh, एक अलग story है. Already we have championed that story, right? Now, glossopharyngeal nerve supplies the posterior part of the tongue. Why? Because the posterior part of the tongue comes from hypobranchial eminence, is what you need to remember. अच्छा, थोड़ा embryology को जनरल एनाटॉमी से मिक्स करके बात करेंगे भाई. So, how is the tongue developed is a very important question. So, fundamentally, there are two elevations that develop caudal to the foramen cecum. The copula in the embryology of the tongue, it comes from the mesenchyme of the second pair of pharyngeal arches. Then the hypopharyngeal eminence, it develops caudal to the copula from the third and fourth pair of arches. That is the reason Glossopharyngeal is the one which is basically supplying it. So, the posterior pharyngeal part of the tongue, जो होता है last one third है ना, that develops from the rostral part of the hypopharyngeal eminence is what you need to remember. Good to see Alek Seth. Now, so let's have one general outlook of what we are talking, doctor. Typically, you have a hypobranchial eminence, which is called copula. There is a primitive pharynx, there is a foramen cecum, and these are the lateral lingual swellings, and this is called tuberculum impar, is what you should remember. So, the two lateral lingual swellings, ये क्या है? This is the lingual swelling, doctor. Lingual swelling. The two lateral lingual swellings, they form the anterior two-thirds of the tongue. Whereas the cranial part of the hypobranchial eminence, it forms the posterior one-third of the tongue and also the circumvallate papillae. And the caudal part of the hypobranchial eminence, it develops the posterior most part of the tongue and epiglottis. Even this is also a favorite question. Epiglottis कहाँ से बनता है? Hypobranchial eminence is the word which you have to basically remember. One of the favorite questions of the examiner. Which structure does not pass through the jugular foramen? Vagus, glossopharyngeal, accessory. They all pass through the jugular foramen. All these cranial nerves, they provide innervation to the structures in the head and neck, except one, which goes all the way additionally to thorax and abdomen also. Which is that structure, doctor? Vagus. Vagus is the, somebody yesterday in the class said, Vagus is the vagabond. वो पूरा बदन में घूमता है, खाली head and neck में रहता नहीं. So that is what you need to remember. The cranial nerve root, which is carrying the parasympathetic fibers, is which one? 7th, 3rd and 9th. Yesterday we have seen oculomotor, then glossopharyngeal, which is carrying to the carotid. 3rd, oculomotor is carrying to the sphincter pupillae. And 7th, facial nerve is carrying the parasympathetic secretomotor fibers to sublingual and submandibular salivary glands is what you have to basically remember. That is the story of glossopharyngeal. Now, let's talk about the veins, doctor. With regard to the cephalic vein, what is the story? Cephalic vein lies in the deltopectoral groove. All of you know, deltoid muscle and pectoral muscle के बीच में deltopectoral groove है. So cephalic vein terminates as axillary vein and it descends in the subcutaneous tissue along the lateral border and it typically passes to the deltopectoral groove. It pierces the clavipectoral fascia is what you have to remember. So this is the clavicle duct, the coracoid process, and here you can find the cephalic vein which is passing between the deltoid and the pectoralis clavi, deltopectoral groove is what you need to remember. With regard to the saphenous vein, what is its anatomical relation with the medial malleolus? It is 1 centimeter anterior to the medial malleolus. Medial malleolus के 1 centimeter. Internship में आप सब लोग venesection किया ना डॉक्टर? Venesection. See, in housemanship एक venesection, एक lumbar puncture, एक pleural effusion tap, चांस मिले तो एक intercostal drainage tube, और doing an intubation. They're all the minimum things, डॉक्टर. जिंदगी में और एक बार चांस नहीं मिलेगा अगर इंटर्नशिप में ये छोटी छोटी खुशियां मिस हो गया तो. सो दैट इज द रीजन एंट्रेंस के लिए टेंशन मत नको लेना, क्योंकि मिल जाएगा सीट, क्यों नहीं मिलेगा. मुरली भरद्वाज के साथ आप रहे तो मिलना ही पड़ेगा. बट द छोटी छोटी खुशियां ऑफ द इंटर्नशिप डॉक्टर यू कैन नॉट अफोर्ड टू मिस. Lifelong to your grandchildren also you will tell, hey, that day I was doing a night duty as a house surgeon. Suddenly a patient came, villager, he had a bull fight. I mean, a bull has come and hit him and he had a spontaneous pneumothorax, all pneumomediastinum. I took the surgical knife and then cut all the skin. Bus, 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 all air is coming out. That night that you sailed with that pneumomediastinum guy, you have to tell that story to your grandchildren. So that chance will never come back in life. Seat तो मिल जाएगा रे, टेंशन कुछ भी नहीं है. Standard topics, standard discussions, be studying every day, focused way, that is very important, doctor. Now, external jugular vein, how is it formed? Posterior auricular vein and the posterior division of the retromandibular vein, they are the ones which form the external jugular vein. External jugular is the counterpart of the external carotid. So obviously the terminal part of it will be superficial temporal. जैसे external carotid artery को क्या है? Superficial temporal artery was the terminal part. Then you have a maxillary which drains into pterygoid plexus. Then there is a posterior auricular. Here you have the retromandibular. Right? Then the facial vein, unlike facial artery is a branch of external carotid, but facial vein drains into internal jugular and typically it forms a connection between external and internal jugular. So let's talk about the external jugular vein. How is it formed? External jugular is typically formed behind the angle of the mandible. There is a landmark. It is the posterior auricular vein, and the posterior division of the retromandibular vein. ये दोनों merge होके आपका external jugular बनेगा. And that's the story. Now, internal jugular vein, how is it basically formed? It is a continuation of the sigmoid sinus, is what you should remember. So, doctor, a little bit about the dural venous sinuses in the calvarium, you have to be very sure about. Keep punching the answers, doctor. From tomorrow onwards, what I am going to do is, I will give you 30 MCQs, 15 minutes time for you. I will give you the link of the quiz. Then and there, when we start class at 7 o'clock, 7 to 7:15 आप वो quiz 30 क्वेश्चंस का फटाफट आपके मोबाइल के ऊपर आंसर करो. 7:15 to 8:15 हम 30 क्वेश्चंस खत्म करेंगे. नेक्स्ट वंस मोर अनदर क्विज दे दूंगा आपको 15 मिनट्स में आप 30 क्वेश्चंस खत्म करो. That way even teacher will get a laryngeal rest, right? Like that 4-5 hours we can be able to study and can be able to finish 120, 150 questions every day. So that is how 600 to 800 questions each subject में last 15 years का question papers topic wise solve करे. तो topic wise करना. All questions belonging to the same topic, we have a computer program which will bring all the questions belong to the same topic to one place. It will give a probability and predictability ratio in the descending order, which is the most commonly asked question in the last 15 years by the examiner, towards descending order. So you get that list. In the descending order we will go. So, आप 30 solve करना, whatever be the knowledge, whatever be your preparation, doesn't matter. For example, anesthesia is your nightmare, doesn't matter. आप like a completely naked brain, you approach, solve that 15 minutes, फटाफट answer करो. Then I will start discussion. It will go like hot अंदर चलेगा, right? So otherwise, if you're a passive listener, no, oh, you feel when this guy will stop, right? So that's important. So doc, this is the superior sagittal sinus and this is the inferior sagittal sinus. Then both of them, it is the straight sinus, which is the connecting link. Then you have a transverse sinus, which is taking a turn here, which is called the sigmoid sinus. Sigmoid se niklega, internal jugular vein is what you have to basically remember. So this is the cavernous sinus, doctor. Cavernous sinus. And ultimately the transverse sinus has got a connection with the cavernous sinus is what you have to remember. So once more, this is a very important graphic that you have to be very sure about. See, this is the superior vena cava. Who is draining into it? Left brachiocephalic and right subclavian, right? So, left brachiocephalic and right brachiocephalic, and from that coming the right subclavian. Now, when you move up from the right subclavian, who is draining into right subclavian? Your external jugular is coming from here and draining into the right subclavian. And here, the transverse cervical, posterior external jugular, they're all draining into the external jugular to ultimately drain to the right subclavian, which is draining into the right brachiocephalic and into the superior vena cava. Then this external jugular basically is formed by the merging of posterior auricular vein, and you have this retromandibular vein, hai na doctor? How is retromandibular formed? Maxillary and superficial temporal together combined to form retromandibular. Retromandibular का posterior branch एक रहता, that is the one which is draining into the external jugular. So the posterior branch of the retromandibular and posterior auricular together, they are forming the external jugular vein is what you need to remember. Then a internal jugular बहुत मोटा रहता है. From that comes the drainage from thyroid and lingual vein and even the facial vein. That is the difference between artery and vein. Artery लिगे तो आपका internal carotid artery doesn't give any branches at all. All this facial, pharyngeal, all these things are external carotid का story होता है. मगर यहाँ तो internal jugular में drain होता है, facial and etc. etc. Now, this facial vein has got a link with the retromandibular vein. So, retromandibular vein that way is draining into external jugular and also it is draining into the facial, and facial is draining into the internal jugular. That's how this retromandibular vein and the facial vein, they both act as a bridge between external jugular and the internal jugular is what you have to ultimately remember. So doctor, once more you can see you have the sternal head of the sternocleidomastoid, a very important relationship, and your internal jugular is very close to it, and your external jugular is passing behind, taking a twist and then coming up. So when you are putting center line, you need to have a bit of idea. But veins generally don't have that much a predictable anatomical course. There are many anomalies. So internal jugular vein कहाँ से तैयार होता? Cranial cavity में sigmoid sinus will be descending down as the internal jugular vein is what you have to basically remember. The sigmoid sinus, this one is descending down as the internal jugular vein is what you need to remember. And the initial part of the internal jugular vein is dilated, and that is called the superior bulb. And the internal jugular basically exits via the jugular foramen is what you have to remember. So doctor, this is how you have a right sigmoid sinus, a very good consolidation of all the story. The right sigmoid sinus, left sigmoid sinus. Typically, when it is descending down through the jugular foramen, there is an enlargement of it, which is called as the jugular bulb. And when it is descending down, it is forming common facial vein, lingual vein, superior thyroid vein, and etc. etc. Then typically external jugular vein is there. External jugular vein through the retromandibular vein and the facial vein will be communicating with it. And ultimately, the internal jugular comes and drains into the right subclavian and here into the left subclavian, into which even the thoracic duct is also draining, is what you have to ultimately remember. How is retromandibular vein is formed is the favorite question of the examiner. Superficial temporal and the maxillary veins combine to form. So parotid gland जो होता है ना doctor, that is the point of merger for all these venous system. So you have the superficial temporal, you have the middle temporal vein, this is the maxillary vein, and this is the retromandibular vein, and this is the facial vein, and this is the posterior auricular vein, and this is the external jugular vein. So this is the anatomical clarity which you need to clearly have. Now, what is the largest vein of the face is the examiner question. Facial vein is the largest vein of the face. So you can see that the retromandibular vein जो है, the posterior branch of the retromandibular vein is traveling to form the external jugular vein. Whereas the anterior branch of the retromandibular vein typically is combining with the facial vein. Facial vein बहुत लंबा है फेस में, उसमें से निकलेगा आपको superior labial vein, then supraorbital, supratrochlear vein, and there's a communication from the facial vein to the superior ophthalmic vein, and then you are having a deep facial vein, inferior labial vein. So they're all draining into the facial vein. That is the reason you need to remember largest vein of the face hota hai facial vein. Now doctor, subclavian vein is a continuation of axillary vein. You all agree with me? Internal jugular vein is a continuation of the sigmoid sinus. वो भी सही है. Brachiocephalic vein is formed behind the sternoclavicular joint, sternum and clavicle के पीछे, by the union of the internal jugular vein and the subclavian vein is what you need to remember. So typically if you take this is superior vena cava, it is giving rise to right brachiocephalic and left brachiocephalic. Left brachiocephalic से निकल रहा है left internal jugular, left external jugular, and that continues to form the left subclavian and the left superior intercostal vein that is also merging into the left subclavian vein is what you need to remember. Then this right internal jugular and right external jugular, they are also draining into The right subclavian vein is what I want to underscore. So how is the superior vena cava formed? It is formed from the brachiocephalic veins are merging to form the superior vena cava is what you should remember. Now doctor, middle thyroid vein, where does it drain into? Question number 332. I like to know what is the answer of all you guys. Come on, click the answer. What the middle thyroid vein, where does it drain into is the favorite question of the examiner. Yes. Punch your answer, doctor. Punch your answer. Middle thyroid vein. Very good. Rituraj is saying internal jugular. Satya, Miz and Rajkumar, everyone is saying internal jugular. Absolutely right. So अगर आप venous drainage of the thyroid देखें तो superior thyroid vein, it accompanies the superior thyroid artery, ends in internal jugular. And middle thyroid vein ends in internal jugular. Inferior thyroid vein, typically it emerges along the lower border of the isthmus, the inferior thyroid vein. It descends in front of the trachea and it drains into left brachiocephalic vein. तो फर्क है, right? So examiner है superior or middle thyroid vein, where does it drain बोले तो आपका आंसर internal jugular vein होना है. मगर if the examiner asks inferior thyroid vein, where does it drain? फटाफट आंसर करना. Left brachiocephalic vein should be your answer. Very important. The retromandibular vein, it drains into pterygoid plexus through the maxillary vein. That is the retromandibular vein. So you should be quite sure on this anatomical perspective. This is the superficial temporal vein and this is the maxillary vein. Even आपको external carotid लिए तो भी आपको maxillary artery है, superficial temporal artery है, दोनों terminal branches of the external carotid artery. Right? First chapter we discussed, no doctor, arteries. एक लगातार 3 घंटे हम discuss किए थे. So it is all there in the online mbbs.com video library, doctor. So archived into it. So take an opportunity to go back and do a review. But ये ऐसे चीज है, first time if you conceptually grasp them in our live discussion, second time revision का जरूरत भी नहीं पड़ना, उतना profoundly pick up करना. That's very important. So this is the retromandibular vein, doctor. Retromandibular vein. So if you look at the external jugular is giving rise to postauricular vein that is coming, and the posterior division of the retromandibular vein is also coming and forming the external jugular. Acha, a retromandibular vein communicates with the maxillary vein, which is communicating through the maxillary plexus of veins. That is what you have to basically remember. Right, doctor? Whereas आपका internal jugular जो है ना डॉक्टर, internal jugular, this one, internal jugular का facial vein उसका बहुत लंबा कहानी है. So it will go a long way, largest vein. So if you look at the maxillary vein, basically it is formed in the infratemporal fossa. It is formed by the drainage from the pterygoid plexus, and it typically drains along with the superficial temporal vein. It will be draining into the retromandibular vein is what you have to remember. Now doctor, facial vein communicates to the cavernous sinus. How does it do? How does it communicate? Superior ophthalmic vein and the pterygoid venous plexus. Through them, the facial vein ultimately communicates with the cavernous sinus. This very important illustration जिसको सही तरफ समझ लेना. भाई आप सबको केवर्नस साइनस का परिचय ऑलरेडी हो गया, राइट? एक केवर्नस साइनस ऐसे चौरस्ता है जिसमें बहुत all roads ultimately lead to cavernous sinus when it comes to veins. So there is a supraorbital vein, then you have a supratrochlear vein. So there is a superior ophthalmic vein and there is a central vein of the retina, inferior ophthalmic vein, and you have this facial vein. This is the facial vein, right? Facial vein. I will try to take myself to this place. Yeah, that's right. So all roads lead to cavernous sinus, and the examiner is very interested to know what are those roads. So a facial vein जो है डॉक्टर, through the deep facial vein, it will go and merge with the pterygoid venous plexus, into which your cavernous sinus is also draining into. Second way, the facial vein also communicates directly with the cavernous sinus. That is the reason अगर कुछ infection dangerous area में infection हो गया तो at the area of the philtrum, it is through the facial vein the infection spreads to the cavernous sinus is what you need to remember. तो हमारा cavernous sinus यहाँ बैठा हुआ है, इसको सारे लोग आके नमस्कार बोल के जाएगा. So this is the inferior petrosal sinus and this is the superior petrosal venous sinus. They both are draining into the cavernous sinus. That is what you need to remember. So doctor, this is another view that you need to be very clear with. आपका ये जो facial vein है ना डॉक्टर, facial vein. So through the deep facial vein, it reaches the pterygoid venous plexus, and from there, typically, even you have a inferior ophthalmic vein, which is coming directly from the what you call the facial vein. So this inferior ophthalmic vein also is ultimately heading towards the cavernous sinus is what you have to remember. So this is a very good summary that you can remember. So basically you have the internal jugular vein here. From this comes the inferior petrosal sinus. Then from the internal jugular only, your superior petrosal sinus is also coming, right? Superior petrosal venous sinus and inferior petrosal venous sinus. Ultimately, they are merging and reaching the cavernous sinus is what you need to remember. Then another way, facial vein through the ophthalmic vein, superior and inferior ophthalmic veins, is also reaching out to the cavernous sinus. So this facial vein to ophthalmic vein to cavernous sinus is the one which is responsible for carrying the infection in the dangerous area of the face is what you have to ultimately remember. Now, internal thoracic veins, they are the tributaries of which vein? Brachiocephalic vein. So आपका दो brachiocephalic veins आके क्या बन रहे? Superior vena cava बन रहे. और a brachiocephalic vein is the one which is the source for the internal thoracic veins is what you have to fundamentally remember. The infection which is spreading from the lower lip first enter the bloodstream through what? Through the inferior labial vein. So you should be very sure this area overlying the philtrum is called as the dangerous area. So you have a superior ophthalmic vein and a deep facial vein, and here you have the cavernous sinus. So the facial vein is connected to the cavernous sinus through the superior ophthalmic vein and provide the source of infection. To have a better अंडरस्टैंडिंग ऑफ द सेम स्टोरी, यहाँ आपका सुप्रा ट्रॉक्लियर वेन है, सुप्रा ऑर्बिटल वेन है, ठीक है डॉक, एंड इसको कहते हैं एंगुलर वेन एट द एंगल ऑफ द आई, एंड दिस इज द फेशियल वेन. From that comes the deep facial vein, and from there it goes to pterygoid venous plexus and go to cavernous sinus. That is one route. Second, from here directly to the superior ophthalmic vein, and that can go to the cavernous sinus. ये दो रास्ते हैं दिल्ली पहुंचने के लिए, you have to be very sure about. So the dangerous area is typically this area. The philtrum, nose, and the angle of the eye. From these areas, through the superior ophthalmic vein, inferior ophthalmic vein, angular vein, deep facial vein, they reach the pterygoid plexus and ultimately reach the cavernous sinus is what you need to remember. So the facial vein through the supraorbital and superior ophthalmic veins, and the facial vein also gives deep facial vein, pterygoid plexus vein, plexus, emissary veins and cavernous. Another way, facial vein, supraorbital, superior ophthalmic vein and go to cavernous sinus. कैसा भी वो cavernous sinus को पहुंच रहा है. That is what examiner is going to ask. So the common facial vein is formed by the union of what are the two veins? Anterior facial vein and the anterior branch of the posterior facial vein. They combine together to form the common facial vein is what you need to remember. So the posterior facial vein, superficial temporal vein and the internal maxillary vein, they both descend together, and it unites with the anterior facial vein. Posterior अगर anterior से मिल गए तो बनेगा common facial vein. That's all. So that is the story of the facial veins, doctor. So yes, how many of you are exhausted of anatomy? And our guys must have prepared the next PowerPoint. Please tell me, doctor, today also, from tomorrow we will have a 15-minute break before 1 hour discussion, so that it will be very interesting for you to play with me. Yeah, I'll try to see whether we got our next, yes, we got it. So doc, we reached the next topic, oculomotor nerve, question number 338. 400 questions tak I am prepared, but I don't know how much energy you have. Still kitna hua? 8:45, right? Do you still have energy? If you have energy, we will continue the batting, right? Huh. So from tomorrow, once you have a 15-minute break where you are answering the quiz and participating 1 hour discussion of 30 questions, every 30 questions. I think that will make us to last longer for 3 to 4 hours of discussion and finish about 120 questions, right? Huh. We will finish another 30 questions fatafat khatam karenge before we call it a day. Anatomy is little slow subject, doctor. We can't help it. Subject is like that, right? Unlike medicine, surgery, gynops, which are more clinical and you feel like rushing through, right? Huh. So now let's make the great start of the next topic. That will be the oculomotor. Ciliary ganglion. Where is it located? Nanda Kumar Neharkar says, continue sir, no problem. We will, हम आगे बढ़ेंगे, right? हाँ, हम कुछ करके दिखाएंगे. We will achieve something and show. That should be the goal. We also have Nalsam, David Hunter. Wonderful team of classmates over here. So privileged. Now, doctor, ciliary ganglion is at the apex of the orbit between the optic nerve and the lateral rectus. Most of you are seduced by the option superior. No, it is lateral rectus. Abhi aa gaya na? So one correction aa gaya. So that is the whole idea. 15 minutes. अगर आप एक quiz फटाफट आंसर करें तो 30 questions, you will find so many questions you are going wrong, and every time you are getting corrected in the discussion, you will get encouragement. So doctor, this is very important to be understood about our eyeball. You have classically the ciliary ganglion is located here. These are the short ciliary nerves, and this is the long ciliary nerve, which is the branch of the nasociliary nerve, which is the branch of the trigeminal ophthalmic division, is what you need to remember. Then from the carotid plexus निकलेगा, I'll try to move that side. Yeah, carotid plexus, you are getting the sympathetic fibers. All of them are ultimately merging on the ciliary ganglion. So this is the optic nerve, and from the ciliary ganglion comes out the short ciliary nerves. Now, doctor, the question comes, where is the ciliary ganglion located? आपका ये lateral rectus है ना doctor? Lateral rectus, right? And optic nerve. This is the optic nerve. At the apex of the orbit between lateral rectus and, sorry, I'll try to come that side. So you can see this is this one is the ciliary ganglion, and the lateral rectus, and this is the optic nerve. So in दोनों के बीच में है the ciliary ganglion. That's what examiner want. Ptosis is because of the damage of oculomotor nerve, because oculomotor nerve supplies levator palpebrae superioris, which elevates the eyelid. And oculomotor nerve, if it is paralyzed, there is an unopposed action of the abducens. That's the reason, and also unopposed action of superior oblique. So the eye become deviated laterally and out, down and out, down and out. That is the fate. Then, what is oculomotor carrying, doctor? Oculomotor nerve is carrying the fibers, parasympathetic fibers to sphincter pupillae. इसलिए अगर sphincter pupillae को कुछ हो गया तो mydriasis, the pupil will go into dilatation, is what you need to remember. Right? Now, Uh, yes. This is another thing, classical ptosis. And if you elevate that eyelid, you will find the pupillary dilation. And the eye is deviated out and down, down and out syndrome कहते हैं इसको. Now, with regard to the oculomotor nerve, good to see commandant. Yes. Now, the oculomotor nerve, it carries parasympathetic, all of you agree. Constriction of the pupils is its function, and it supplies the inferior oblique muscle, whereas superior oblique is supplied by the trochlear, as all of you know very well. Very good. Commandant is our topper doing MD General Medicine in Armed Force Medical College. Very good. So what is the topic you have chosen, Commandant, for your thesis? Thesis in MD is like a formality, unfortunately, in most of the medical colleges. But if you really try to do something, that is the first time you are creating a research paper, right? So doctor, always remember, जिंदगी में पोस्ट ग्रेजुएशन में सीट मिलने से क्या होता? कुछ भी नहीं होता. We don't get two horns. We are in a cohort called undergraduates. What is our only objective when we are doing our BDS or MBBS? College function, falling in love, dumping somebody, getting dumped by somebody, right? Monthly 2-3 nice movies, right? Cricket khelna, life aram se 4.5 years is over. So we are in that cohort at that time. PG preparation में हमारा cohort बदल जाता है. We are in the cohort like this. We have to do revision of all 30,000 questions, somehow get the concepts, do the revision and get the top rank. उसके बाद हमारा cohort post graduation में सीट मिलने के बाद और एक cohort पे और एक cohort के अंदर जाएंगे. Life doesn't change. And post graduation final year में टेंशन रहता है, प्रोफेसर हमको पास करेगा या नहीं करेगा. The day I laughed at him, the day I did not salute him, पास करेगा, उसको याद है क्या वो, all that. After that, you become a consultant. You are in a different cohort of consultants. तेरा प्रैक्टिस कैसा है रे, मेरा प्रैक्टिस ऐसा है रे, मेरा कार मर्सिडीज बेंज है रे, तेरा कार क्या है रे, right? So life is different stages of drama, doctor. You should learn to enjoy every stage of the drama, right? Then only you have fully lived a life. So that is the reason never say मुझे anxiety आ रहा है, tension आ रहा है, depression आ रहा है. क्यों आना है? हम तो इस नौटंकी में अभी ये particular role play कर रहे हैं. That's all. That's the only thing. Let us play that role very well. Villain का role हो, hero का role हो, कुछ भी हो, chance मिलेगा. So we have to perform that role with full passion. Then you will enjoy doing everything like our commandant, who had been an active participant just like all you guys, right? You are participating now. Last October, November, December, January, commandant. He was bombing the answers. Today, he's a proud topper, got into MD General Medicine. But once more, another challenge started in the life. So that should be your story, doctor, right? So, oculomotor nerve, it does not pass through inferior orbital fissure. You all know very well, आपका ये superior orbital fissure जो है, midbrain से निकले हुए ये oculomotor को, please come inside बोल के invite करेगा. So it is the superior orbital fissure through which the oculomotor nerve is passing is what you need to remember. So oculomotor nerve passes through superior orbital fissure. Damage to the oculomotor lead to ptosis and mydriasis, not miasis. And outward deviation, downward deviation and डिप्लोपिया। एक आंख उस तरफ देख रहे हैं और एक आंख ऐसा देख रहे हैं, क्या होता है? डिप्लोपिया होगा. Now, doctor, so you can see here that the oculomotor कहां से निकल रहे हैं? मिड ब्रेन से निकल के बाहर आ रहे हैं, right? Then one important point you should remember here. What is your circle of Willis? The two vertebral arteries combine to form basilar artery. Basilar artery divides into posterior cerebral artery. Right? Vertebral arteries combine to form basilar artery. Basilar artery divides into posterior cerebral artery. Meanwhile, आपका internal carotid artery will be giving rise to the middle cerebral artery, anterocerebral artery, and it gives one branch called PCOM, posterior communicating artery. Comes from, is a branch of internal carotid artery. So, a posterior communicating artery coming from the internal carotid comes and joins the posterior cerebral artery. So, this typically happens at the midbrain level. This posterior cerebral artery, posterior communicating artery coming and joining typically happens at the level of the midbrain, the place where your oculomotor nerve is coming. अगर इस posterior communicating artery को कुछ aneurysm हो गया, then it will compress the oculomotor nerve is what you have to basically remember. So once more, in order to give you a clarity, थोड़ा anatomy landmarks को master करेंगे. This is the levator palpebrae superioris, and which is elevating your eyelid. Then this is your superior oblique muscle, right? It has got a trochlea through which it curves. इसलिए इसको सप्लाई करने वाले ट्रॉक्लियर नर्व को ट्रॉक्लियर नर्व कहते हैं. Then you have the superior rectus. Then this is the ciliary ganglion, right? Now, this is the optic nerve which is passing. Then, doctor, here you are having your lateral rectus which is passing. And typically, the internal carotid will be giving rise to the posterior communicating artery. And your oculomotor nerve from the midbrain निकल के आंख के ऑर्बिट के अंदर जाने की जर्नी में है. That time your posterior communicating artery, if it develops an aneurysm, it will compress this oculomotor nerve which is coming out of it, is what you need to remember. So oculomotor nerve palsy can occur because of the posterior communicating artery aneurysm. और एक डायरेक्शन में अगर आप देखें तो you can remember this is the posterior cerebral artery, doctor. And typically your oculomotor nerve is passing from the midbrain and leaving. And if there is any aneurysm here, it will compress the oculomotor. Now one important point you should remember. A oculomotor nerve में you have what is oculomotor nerve doing? It is carrying parasympathetic fibers with it. What else it is carrying? It is also carrying the extraocular muscles को supply कर रहे हैं. वो fibers भी लेके जा रहे हैं. Levator palpebrae superioris का fibers को भी लेके जा रहे हैं. Motor fibers. Right, motor fibers. Now, if you look at these extraocular muscles and the levator palpebrae superioris को जाने वाले motor fibers जो हैं, वो oculomotor nerve के सेंटर में रहते. पेरिफेरी में आपका पैरासिम्पैथेटिक फाइबर्स रहते. Now, there is one cause, medical cause that lead to oculomotor palsy. What is that? Diabetes. क्यों? Diabetes में there will be arteriosclerosis, atherosclerosis and arteriosclerosis of the small vessels that supply the nerve. नर्व को सप्लाई करने वाले स्मॉल फाइबर्स, उसको क्या बोलते हैं? वैसा नर्वोजम. अगर वैसा नर्वोजम में लिपिड डिपॉजिट होके वैसा नर्वोजम ब्लॉक हो गया तो देन द ब्लड सप्लाई टू द central part of the nerve get most affected, which is having the motor fibers. But the peripheral part, which is having parasympathetic fibers, it is not affected. So, इसलिए if the oculomotor palsy occurs because of the diabetes, medical causes, then the motor fibers are affected, but not the parasympathetic fibers affected. Parasympathetic fibers, if they are not affected, then the pupil is normal, it is not mydriatic. So a normal pupil will be there, but there will be ptosis and the eye will go deviate downward and outward. वो सब चीजें रहते, मोटार का दिक्कत होता है, मगर parasympathetic effects नहीं रहता if the underlying cause is diabetes. But if the oculomotor palsy is because of a surgical cause, let us say the PCOM aneurysm has compressed it, then both the peripheral and the inner fibers, outer fibers, both of them got affected, and you get a mydriasis also if the cause is surgical. So what will you remember? The medical causes of the oculomotor palsy will be pupil sparing, whereas surgical causes of the oculomotor palsy, pupillary involvement is seen. That's the reason whenever a patient comes to you, how do they come, doctor? He will come with oculomotor palsy है तो कैसे आएगा? ऐसे आएगा, टोसिस के साथ आएगा. देन आप eyelid को ऊपर करे तो, if you lift the eyelid, then if you see pupillary dilatation, what will you do immediately? Immediately you will call your neurosurgery resident, and also you will send the patient for getting a angiogram done, and contrast will pass into the circle of Willis. There the posterior cerebral artery aneurysm will be identified and the surgeon will take care. But if you lift the eyelid, pupil is normal, then you will ask, do you have a history of diabetes? Patient will say, yes doctor, I have diabetes. मेरा glycosylated hemoglobin है 12-13 और मेरा fasting sugar रहता है 200-240. I don't have any wish to live, doctor. Please, patient will say, right? So diabetes like conditions में patients को they need to have a discipline to maintain the glucose. If they maintain that with a good glycemic control, complications will run far away. So that is the reason the most important point you need to remember is medical causes में pupil will be spared in oculomotor palsy. Pupil involving oculomotor palsy is because of the surgical causes like PCOM aneurysm is what you have to ultimately remember. That is the question in the All India Postgraduate Dental Entrance Exam 2015 में. Which nerve is compressed by the aneurysm of the posterior communicating artery? What is your answer? Oculomotor nerve is what you need to remember. Loss of both direct and consensual light reflex is because of the lesion of what? It is because of the lesion of oculomotor nerve. Now light reflex ka story फटाफट बोलो, right? So you should remember that retina के ऊपर light लगाए तो it is carried by optic nerve. Optic nerve reaches in the midbrain pretectal nuclei. From pretectal nuclei, both sides Edinger-Westphal nucleus को information जाएगा. Then from Edinger-Westphal, typically the oculomotor carries it to ciliary ganglion, and from the ciliary ganglion it will carry it to the short ciliary nerves to the ciliary sphincter. So that is the reason एक eye में light मारे तो not only ipsilateral pupil constricts, contralateral pupil also constricts. And why that decussation is happening, why that consensuality is happening? It is happening because from pretectal, both sides Edinger-Westphal have been communicated is what you have to basically remember. एक eye में light मारे तो वो constrict होगा, that is direct light reflex. और दूसरा eye भी constrict होगा pupil, उसको बोलते हैं consensual light reflex is what you need to remember. Then one more important reflex is the corneal reflex. मौका आगे ना एक बार रिविजन करेंगे. Typically, if you do a light touch with a wisp of cotton, the nasociliary branch of the ophthalmic nerve will perceive that you touched it. Ophthalmic is the branch of trigeminal. So typically through the ophthalmic nerve, it will tell to the trigeminal sensory nucleus in the pons. And that in turn will communicate to the facial motor nucleus on both the sides. And that will in turn send branches, temporal and zygomatic branches of the 7th cranial nerve. They supply the orbicularis oculi muscle, and that lead to immediately closure of your eyelid. So efferent is facial, afferent is trigeminal in case of the corneal reflex is what you need to remember. Ptosis can occur because of the damage of the oculomotor is what you should remember. So this is the levator palpebrae superioris muscle, doctor, which you can see. So it will be attaching to the palpebral fissure and responsible for elevating our eyelid and supplied by the oculomotor. And this is the orbicularis oculi muscle, and that is the one which is supplied by the 7th cranial nerve is what you have to emphatically remember. Are you able to get the broadcast, doctor, clearly? I'm just wondering, is the broadcast problem in broadcasting? Okay. How is it now, doctor? Is it fine now? Is the broadcast okay for you? I'm able to see a normal broadcast here. Can the online students can punch? Yeah, RT is saying now it is okay. Very good. So, excellent. So, I hope you are able to get this picture. Do I need to go back? Can you please punch? Can we continue from here? Did you miss a lot in the middle? Can we continue or do we need to go back to the backslide? Can you please say? Do we need to go back to the backslide or we can continue? Okay. So that is the story, doctor. Now, paralysis of the upper eyelid. Continue. Okay. Eyelid is because of due to the third cranial nerve. Oculomotor nerve supplies which muscles, doctor? Lateral rectus is by abducens. Superior oblique by trochlear. So only superior rectus is supplied by the oculomotor. So you should remember superior rectus, medial rectus, inferior oblique, levator palpebrae are all oculomotor. Abducens is the lateral rectus and trochlear is the superior oblique is what you need to remember. Now, which is the dilator of the palpebral fissure? It is the levator palpebrae superioris. So, if you look at the various functional groups of the facial muscles, the palpebral fissure, the sphincter is orbicularis oculi, and the dilator is levator labii superioris and occipitofrontalis. Oral fissure, it is the orbicularis oris, except mentalis, all the other muscles are the dilators. Is what you need to remember. Mentalis and orbicularis oris, everything else is dilated for the oral fissure. Oral fissure sphincter is the orbicularis oris. Nostrils, the sphincter is compressor naris, whereas the dilator naris and depressor septi and levae labii alaquae nasi, they are all considered to be the dilators, is what you need to remember. Where is the lacrimal gland located? It is typically located in the groove which is overlapped by the levator palpebrae superioris, is what you need to remember. So this is very important to recognize, doctors. What you have here, this one is the lacrimal gland. So this is the levator palpebrae superioris and its aponeurosis. And this is called Vital's ligament, otherwise called superior transverse ligament is the name given. So typically lacrimal gland is the groove which is being sitting in the groove formed by this levator palpebrae superioris, is what you have to ultimately remember. So that is the story of the oculomotor nerve. Let's talk about the most important topic, cavernous sinus. The danger area of the face is called danger because the facial veins to cavernous sinus, how are they connected with each other? Superior ophthalmic vein is the one which is connecting them. So this is a very important illustration that you need to master, doctor. This is called angular vein. इसको कहते हैं angular vein. This is the facial vein and this is the inferior ophthalmic vein and this is the superior ophthalmic vein. ये inferior होता है, ये superior ophthalmic vein. So through the angular vein, superior ophthalmic vein, inferior ophthalmic vein, the drainage is happening into the cavernous sinus. Then the facial vein also communicates to the pterygoid venous plexus, and the deep facial vein also comes to pterygoid venous plexus. Maxillary vein also drains into pterygoid venous plexus, which ultimately drains into the cavernous sinus. This is how all the roads are leading to the cavernous sinus, is what you need to remember, which is a paired venous sinus of the dura mater. The cavernous sinus, superior petrosal transverse sinus, they are all paired. So this is the very important structure, doctor. Superior sagittal sinus, This is the inferior sagittal sinus, and you can see the falx cerebri, which is located here. And typically you have a straight sinus, which is ultimately uh, um, merging with the confluence of sinuses is happening. And from the sigmoid sinus, this is the sigmoid sinus, this is the straight sinus. So sigmoid sinus से निकल रहा है आपका internal jugular vein is what you need to remember. So this is another way, a much more cosmetic way of looking at the things. So you can see this is the superior sagittal sinus, inferior sagittal sinus. ये दोनों को मिलावट through straight sinus, which is forming confluence of the sinus, and this is the occipital sinus. Here you have the transverse sinus, which is taking a turn called sigmoid sinus, from which you are getting the internal jugular vein, and this inferior petrosal sinus, superior petrosal sinus, sphenoparietal sinus, all these are merging into the ipsilateral cavernous sinus. The system cavernous also, you have a bilateral structure, and the cavernous sinus is also communicating with the sigmoid sinus. That is what you have to basically remember, right? So it is the straight sinus anomalous formation. You will find the vein of Galen, which can lead to congestive heart failure in pediatric population, vein of Galen. Now, the cavernous sinus communicates directly with everything except. So you should remember the veins in the orbit, pterygoid venous plexus, inferior petrosal sinus, they're all directly connected with the cavernous sinus is what you have to remember. So now let's look into it, doctor, this very important anatomical story. Once more, I'm trying to reinforce the same thing from a different views. ये है आपका cavernous sinus, superior ophthalmic vein directly communicating, then inferior ophthalmic vein directly communicating, and यहाँ रहने वाले pterygoid plexus also directly communicating. Then the superficial middle cerebral vein is also communicating, and this is the inferior petrosal sinus, and superior petrosal sinus and inferior petrosal sinus. So a sigmoid को directly it is not communicating. It is communicating through inferior petrosal and superior petrosal sinus. That is what examiner is asking. Sigmoid sinus को, straight sinus को, transverse sinus को direct communication है क्या बोल के पूछ रहे हैं एग्जामिनर. सो आपका जवाब क्या है? नहीं भाई, transverse sinus is associated with inferior petrosal sinus to drain. Sigmoid sinus through the inferior petrosal sinus, transverse sinus through the superior petrosal sinus. So there is no direct communication between cavernous sinus, straight sinus, and transverse sinus and sigmoid sinus. That's what you need to remember. So doctor, this is the favorite short answer question in the anatomy days. My God, scary question. Write a short notes on cavernous sinus. So be very sure. Superior ophthalmic vein, inferior ophthalmic vein and central vein of the retina, ये सब चीजें आके cavernous sinus के अंदर merge हो जाएगा. Then middle meningeal vein, sphenoparietal sinus from the meninges merge with the cavernous sinus. From the brain, superficial middle cerebral vein, inferior cerebral vein also will drain into cavernous sinus. Then from the orbit, facial vein into that, the pterygoid plexus of veins will be draining, and they pass through an emissary vein which passes through the foramen ovale and spinosum is what you need to remember. Then pterygoid venous plexus is also directly connected with the cavernous sinus. So that is the important part of the story. Now, where is the dangerous area of the face, doctor? Fatafat answer karo. Dangerous area of the face. It is the area which is being drained by the angular facial vein is what you have to remember. So doctor, as I told you once more, superior ophthalmic vein, angular vein, inferior ophthalmic vein, this is the area which is draining into the cavernous sinus. The tributary of the cavernous sinus, what are they? Now you are the champion in this topic. Superior petersal sinus, inferior petersal sinus, superficial middle cerebral vein, they're all the ones which are the tributaries of the cavernous sinus you have to be very sure about. The transverse venous sinus continues as what? So if you know this illustration, you will be able to remember. See, this is the superior sagittal sinus, inferior sagittal sinus. This is the sigmoid sinus. So this is the transverse sinus on the right, transverse sinus on the left, which is becoming left sigmoid sinus. So that is the reason. What is your answer? The transverse venous sinus will continue as the sigmoid sinus. As the sigmoid sinus is what you have to ultimately remember. Now these are all the structures which are in the lateral wall of the cavernous sinus. What are the structures which are there in the lateral wall of the cavernous sinus? Favorite question. Ophthalmic nerve, trochlear nerve and the oculomotor nerve. अच्छा, अभी cavernous sinus का lateral wall में क्या है, medial wall में क्या है, हम गर्मा गर्म पढ़ेंगे. भाई आपका हाइपोफाइसिस सेरिब्रे पिट्यूटरी यहाँ है, उसके आजू बाजू में है केवर्नस साइनस. केवर्नस साइनस, इस केवर्नस साइनस का लेटरल वॉल में यू आर हैविंग ऑक्यूलोमोटर नर्व, द ट्रोक्लियर नर्व, ऑफ्थैल्मिक नर्व, मैक्सिलरी नर्व, ये सब चीजें उसके आजू बाजू में हैं. देन इसके मीडियल वॉल को रिलेटेड है, लेटरल वॉल को नहीं, मीडियल वॉल को रिलेटेड है एब्डसेंट नर्व एंड इंटरनल कैरोटिड आर्टरी. ये पॉइंट आपके दिमाग में बैठ गए तो एग्जामिनर का कुछ भी क्वेश्चन आप आंसर कर सकते. एंड व्हाट इज द पैरानासल साइनस व्हिच इज वेरी क्लोजली रिलेटेड टू द केवर्नस साइनस? इट इज द स्फेनोइड साइनस व्हिच इज द पैरानासल साइनस व्हिच इज क्लोजली रिलेटेड टू the cavernous sinus is what you need to remember. और एक बार फटाफट बोलो. Oculomotor nerve, trochlear nerve, ophthalmic division of the fifth cranial nerve, maxillary nerve, mandibular nerve. Mandibular nerve तो जरा दूर है, मगर lateral wall में ये चार है. Oculomotor, trochlear, ophthalmic and maxillary is what you need to basically remember. शेषा गोपालन लेटेस्ट बात बोल रहे हैं. सर जी, मैक्सिलरी नर्व जैसे मैंडिबुलर नर्व बाहर है, लेटेस्ट बुक्स में मैक्सिलरी नर्व को निकाल दिए. ग्रेस एनाटॉमी का दिनों का बात कर रहे हैं आप. हाँ, वेरी गुड. सो ऑलवेज स्टूडेंट्स आर द बेस्ट टीचर्स बिकॉज यू आर मोर मॉडर्न एंड मोर अप टू डेट, राइट? सो प्राउड ऑफ यू शेषा. शेषा, you are in which year of MBBS? First year, second year, which year of MBBS? Yeah. So, very good to know maxillary is being removed from the lateral wall in the latest books. But yeah. Now, doctor, cavernous sinus, what are the structures which are related to it? So, you should remember that fourth nerve, sixth nerve also is related. I'm not talking lateral wall or medial wall, right? And mandibular division of the trigeminal, right? Very good. Sesha Gopalan is saying, sir, now second year started, MBBS. Very good, very good. So शेषा गोपालन का फोटो मिल गए तो हम नेक्स्ट एग्जाम का टॉपर है. By the time 3 years later, when Sesha joins the enters into final year, next आएगा, हाँ? तो अभी तो you should be well prepared from now only to even take a license to become practice and enter into housemanship. So that has become a bit scary and little, nothing scary. Point is, MCQ exam is more easier to crack than writing theory, right? So anyway, you need to prepare for entrance exam, right? Now, which structure does not pass through the cavernous sinus is the examiner's question. So you should remember oculomotor, trochlear, trigeminal, all of them pass. Why will middle cerebral artery will pass? Which is not a branch of the cavernous part of the internal carotid artery. अच्छा, ये बहुत बढ़िया question है, right? Definitely. So students like Sesha Gopalan and Ranjit Shaw, you're all a inspiration for the teachers. Let me tell you that हम 25 साल के पहले 27 years before I was a second year MBBS student, right? So even today I feel like I am a first year MBBS student while preparing for the class. Thanks to all you guys, right? So if you all pay the fee, enjoy the free as much as you can, but you also buy the subscription and enjoy the full video library, right, Doc? Then I can bring many more teachers. Most of the teachers, they charge almost 4,000 rupees per hour to teach. So I am unable to afford to pay. Since I am passionate in teaching, 20 years back when I started coaching, I didn't have much of teachers. So that's the reason I only used to teach all 19 subjects, and even today I have that kind of a love to teach, because ultimately a teacher is nothing but a facilitator. I'm like a DJ for you guys, right? I'm little bit prepared and came for the music of the evening pub, our NEETPG preparation pub. So, so you join, buy the subscription, enjoy the online mock tests on every Sunday with the discussion, do a revision of the video library, and once a good number of students join, I'm very sure I will get an opportunity to get a lot more number of teachers and more longer sessions, right? Now, yes, meningeal artery, inferior hypophyseal artery, and cavernous branch. So, doctor, if you look at the important thing is, see, this is the carotid part, doctor, cervical part of the carotid artery, and this is called as the petrous part, which is passing closer to petrous part. Then you have the cavernous part, Then you have a carotid siphon, and it enters, this is called the cerebral part, and ultimately it will break down into middle cerebral artery and anterocerebral artery and a posterior communicating artery and a ophthalmic artery, which all arise from the cerebral part. Now the examiner's question is, from this cavernous part, what are the branches is a very important question. So you should remember, cervical part mein there are no branches. Cavernous part mein there are cavernous branches of the internal carotid that go and supply the trigeminal ganglion. Similarly, आपको cavernous part में जब internal carotid is passing through the cavernous sinus, उसके बहुत नजदीक में कौन है? Pituitary gland है. इसलिए superior and inferior hypophyseal branches to the pituitary gland also are the branches of the carotid when it is passing through the cavernous part, is what you need to remember. So, types of joints. is our next favorite topic with which आज का कार्यक्रम को हम समाप्त करेंगे. So we will take up the joint types. Okay, doc. So tomorrow onwards, I won't bore you this much. I will give you 15 minutes questions, 30 questions to answer in 15 minutes. Clock will be ticking. 1 hour discuss करेंगे. फिर once more 15 minutes quiz answer करो instantly. Right? We will make that. A non-synovial joint with a connective tissue in between it. What is it called as? 361. Punch your answer, doctor. Let me see how will be your answer. What will be your answer? Let me see your depth of perception on this topic. Come on. Give me your fatafat answer. Question number 361. What is your answer? A non-synovial joint with a connective tissue between. What is it called as? Between it, what is it called as? Question number 361. Yes. One strong and loud answer. Non-synovial joint with connective tissue in between. I'm waiting for the answer. So you should remember that syndesmosis is the name which is being given for a non-synovial joint with a connective tissue in between is what you should remember. Syndesmosis. Now, doctor, if you look at the classification of the joints, Indrajit Kumar, Yuvashri, you are differing between B and C. Sesha Gopalan also, clean bowl with synchondrosis, no sir. It is syndesmosis. Connective tissue है इसके बीच में. अच्छा. That means another 5 minutes or 10 minutes of investment of time on this topic is worth. Now, doctor, how do you classify the joints? Fibrous joints, cartilaginous joints, synovial joints. बोल के 3 तरफ के joints हैं. Fibrous joints में sutures, gomphosis, syndesmosis. Fibrous क्यों बोलते बोले तो they are connected by, held together by the fibrous tissue. Then cartilaginous joints में you have a primary cartilaginous joint, secondary cartilaginous joint. Primary को कहते हैं synchondrosis. Synchondrosis is the primary cartilaginous joint. Whereas symphysis, right, is basically called secondary cartilaginous joint. Then, what is a synovial joint? Synovial is a very freely mobile joint with the articulating bone separated by a joint cavity जिसके अंदर synovial fluid रहता है. So, in summary, you have fibrous joint, cartilaginous joint, synovial joint is the broad classification of the joints. अच्छा, fibrous joint के बारे में बात करेंगे. How many types of fibrous joints do you know, doctor? Sutures, syndesmosis, gomphosis. So, fibrous joints fundamentally, they have very little movement or sometimes no movement. That's the important thing. The skull sutures, inferior tibiofibular joint is a syndesmosis. Inferior tibiofibular joint is syndesmosis. And between the teeth and the jaw, it is a gomphosis. Gomphosis is also a fibrous joint is what you should remember. Now sutures, they are found between the skull bones, they do not allow any movement, and these joints ossify, sutures ossify as you grow and as you age is what you should remember. Syndesmosis, there is no movement between them and they do not ossify, and classical example of a syndesmosis is the interosseous membrane that you have between radius and ulna, right? Upper limb. Similarly, Between the tibia and fibula, the interosseous membrane that you have in the distal tibiofibular joint is also an example of syndesmosis, is what you need to remember. What is a gomphosis? Joints that connect the teeth to their sockets in the maxilla and mandible, and the fibrous connection is the periodontal ligament. A periodontal ligament is that fibrous connection, and the teeth and the maxilla or mandible is basically called as the gomphosis. And there is a very little movement during chewing because of this tight periodontal ligament which is connecting, is what you should remember. That is the story of our first type of joint, which is the fibrous joint. अच्छा, 1-2 comments about cartilaginous joint के बारे में बोलो. Primary cartilaginous, secondary cartilaginous. Primary cartilaginous को बोलते हैं sympchondrosis, secondary को कहते हैं symphysis. So primary cartilage का sympchondrosis जो होता है, the bones are connected by a hyaline cartilage, whereas secondary cartilaginous joints में it is a white fibrocartilage which is connecting. Difference is hyaline cartilage जहाँ रहता है there is no movement, whereas white fibrocartilage will let the secondary cartilaginous joint, that is a symphysis joint, to have a limited movement, is what you have to ultimately remember. So the epiphyseal cartilage of a growing bone, epiphyseal cartilage, is a primary cartilaginous joint, whereas the intervertebral disc and the symphysis pubis जो है, that is a secondary cartilaginous joint, is what you have to emphatically remember. So in the primary cartilaginous joints, doctor, there is a synchondrosis. 1-2 comments about each of them. There is no movement. Epiphyseal plate and first sternocostal joint are the examples of the primary cartilaginous synchondrosis. The example, best example is first sternocostal joint. Lot of times this question was asked. Similarly, the epiphyseal plate with its hyaline cartilage is an example of primary cartilaginous. Primary cartilaginous का दूसरा नाम synchondrosis is what you have to ultimately remember. Then secondary cartilaginous symphysis, all of you know, there are intervertebral discs. Then there is a symphysis pubis, intervertebral disc, symphysis pubis, and manubrium sterni, manubriosternal joint जो होता है, manubrium and sternum, ये दोनों के बीच में manubriosternal joint जो होता है, that is a secondary cartilaginous or a symphysis joint, is what you need to remember. ये देखने में बहुत easy लगता है, मगर examiner ने इसी को घुमा घुमा के पूछेगा entrance में, and you have to be sure to answer it correctly. अभी आ गया synovial joint. अरे इसके बारे में 2-3 बात बोलो. The articular surfaces of a synovial joint, most of the joints in the body are synovial. It is covered by hyaline cartilage and the bones are held together by a fibrous capsule. आपको दिख रहा है ना? A ligament है. I'll come that side. Yeah. So you have the fibrous capsule and there is a synovial membrane which you are able to see, right? So the bones are held together by a fibrous capsule and the capsule is lined by the synovial membrane and they secrete the synovial fluid, and the synovial membrane does not cover the articular cartilage. And the articular surfaces are covered by the hyaline cartilage. That is what you have to understand. So, अगर आप structure of a synovial joint देखें तो आपको एक articular cartilage होगा, right, doc? So this is the articular cartilage. Articular cartilage. Here अगर आप देखें तो this is the articular cartilage. Then there is a fibrous capsule as what you can see. Then there is a synovial membrane and the joint cavity. These are the components. This is another view for you to understand. So this is all the fibrous capsule. These are the ligaments, typically between humerus, radius and tibia. And here you can see the articular cartilage is what you should understand. Now, what is the classification of these synovial joints? Uniaxial, biaxial, multiaxial, कितने axis के ऊपर ये घूम रहे हैं, उसको different axial बनाया. Let us talk about uniaxial joints. Uniaxial joints में दो तरीके के होते हैं, एक hinge joint और एक pivot joint. बराबर? Now, what is the shape of the articular surface if it is a hinge joint? It is concavo-convex. Whereas the pivot is surrounded by a ring. That is a pivot joint. Here the movement in a hinge joint is around a transverse, axis transverse रहता है उसके ऊपर. जैसे आप एक book है, book का pages, how are they? They are like a hinge. Whereas pivot is around a vertical axis. So अगर आप flexion कर रहे हैं और supination कर रहे हैं, flexion और extension कर रहे हैं, then around a horizontal axis ये सब हो रहा है, वो होता है hinge joint, like elbow joint or an interphalangeal joint. Whereas rotation, if there is a rotation moment, that is pivot. Pronation, supination along a vertical axis, pronation, supination is occurring. Rotation is occurring. Like a superior radio-ulnar, atlantoaxial. They are the examples of pivot joint. Pivot or hinge joint are uniaxial joints is what you need to remember. और एक बार summarize करो doc. Pivot and hinge joint. Around a transverse axis, around a vertical axis, uniaxial is one system. Then biaxial is an ellipsoid or a condyloid joint, and saddle joint are biaxial. And ball and socket is a multi-axial synovial joint. This you have to be very sure about. Right? Now, हम फटाफट देखेंगे. देखो जनाब, ये हिंज जॉइंट है बिटवीन ह्यूमरस एंड अल्ना, जहां फ्लेक्शन एक्सटेंशन होता है. Flexion, extension are happening. So a hinge joint typically is what you see in case of elbow joint. Then atlantoaxial joint, typically around a vertical axis rotation हो रहा है. How do we do Bharatanatyam? Right? Atlantoaxial joint, which is a vertical axis, is what you need to remember. So doctor, one more example of the pivot joint is your head of the radius. This is the annular ligament. Supination, pronation, supination, pronation. कैसे हो रहे? Because radio-ulnar joint is a pivot joint is what you have to ultimately remember. अच्छा भाई, biaxial joints के बारे में बात करेंगे. Ellipsoid joint इसको कहते हैं condyloid and a saddle joint. These two are biaxial joints. Doc, ये सारे PowerPoints are available in the onlinembbs.com. So you join and ask your classmates also to buy the subscription. आपको वीडियो भी मिलेगा, वीडियो के नीचे पीपीटी भी मिलेगा, उसके नीचे आपका कमेंट्स भी एंटर कर सकते, और एनी टाइम यू कैन डू द रिविजन either on a smartphone or on a laptop, anywhere you can be able to do. So that is a great advantage today. Live online, face-to-face, live online class is more effective than the classroom face-to-face, where there is not much of interaction in a crowded classroom, very costly. Whereas live online जो होता है, कहीं भी बैठो, happily traveling का जरूरत नहीं है. और if live face-to-face classes are about 70,000-80,000 rupees coaching, this comes for as cheap as anything, even 1 rupee, 0 rupee also. जैसे अभी हमको free class चल रहा है, right? So that is a great advantage. So all the future is only live online, be very sure. So you're also going to become clinicians, going to give online consultations. So you're going to follow up the patient on the smartphone. A lot of messaging is happening nowadays, right? So you're able to keep in touch with your patients also, follow-up care. No need that patient need to all the way travel to you to have a face-to-face talk with you for 2 minutes and wait in a long queue, right? So we're all in the modern era. So what is the shape of the articular surface? Typically oval convex surface fitting a ellipsoid concavity, whereas saddle may both articular surfaces are concavo-convex. So where do you find the ellipsoid, otherwise called condyloid joint, is the examiner's question. Wrist joint and metacarpophalangeal joint. Metacarpophalangeal joint. MCP. Metacarpal bone and phalanxes के बीच में. Whereas interphalangeal joint is what kind of joint, doctor? Once more, interphalangeal is a hinge joint, whereas metacarpophalangeal is ellipsoid joint. Then what are the saddle joints? यहाँ flexion, extension, adduction, abduction and a slight rotation होता. Adduction, abduction, ellipsoid में भी होता. Flexion, extension, ellipsoid में भी होता. मगर shape different होता है surface का. So carpo-metacarpal joint of the thumb is a classical example of a saddle joint, is what you need to basically remember. Now doc, this is what we are talking about. The ellipsoid joint, best example is metacarpophalangeal joints. Then condyloid joint, example is between radius and scaphoid and the lunate bones and the carpus in the wrist are the classical example. Then carpo-metacarpal joint of the thumb, don't forget, favorite question of the examiner, saddle joint hai. Both surfaces are concavo-convex, that is the importance. Finally comes the multi-axial joints. Almost we are done. No worries. I know you're all hungry, right? हम almost 3 घंटे से लगातार पढ़ रहे हैं. हाँ, बढ़िया. So, ball and socket joint, shoulder joint, hip joint, classical examples. So here you have a ball and socket shoulder, and also in the hip you have the ball and socket. Orthopedician का पूरा जिंदगी ये ball and socket में ball को fit करने में, prosthesis में, hip replacement में, right? Bread and butter of all the orthopedic surgeons. So that is the summary, doctor. Uniaxial is hinge and pivot, biaxial is condyloid and saddle, multiaxial is ball and socket is what you need to remember. Lastly comes the plane joint. Plane means articular surfaces are flat. It will only allow sliding, gliding, sliding, gliding. आपके foot में between navicular and the cuneiform bones intertarsal joint होता है ना doctor, intertarsal joint, that is an example of a pivot joint is what you have to basically remember. Now doctor, the fusion of two bony structures within a ligament, what is that called as? It is called as syndesmosis. यहाँ से everything is skating. एक बार concept आ गए तो run, 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 run. Which is the joint? in the ossicles of the ear? Beautiful question. It is the synovial joint. So you should remember malleus, which has a handle and a head, incus, and then stapes, which has a foot plate. Miss, a miss के बीच में होने वाला जो joint है, it is a synovial joint is what you need to basically remember. A slightly movable articulation in which the contiguous bony surfaces are connected by flattened disc of fibrocartilage or an interosseous ligament. What do you like to call this as? अच्छा डॉक्टर, इसका एक रॉन्ग आंसर बोलो, मैं अब भी बंद करूंगा सेशन को, राइट? सो please tell a wrong answer. Then I will stop the session. If you tell right answer, I will continue. There is a risk. जागो जागो 364 क्वेश्चन नंबर मार के आपका आंसर बताओ. Slightly movable articulation in which contiguous bony surface are either connected by सत्य स्निग्ध त्रिपाठी जी बोल रहे हैं. यहाँ के आंसर्स try to fit it into the answers over here. Yeah. इसका रॉन्ग आंसर जिसको मिलता है उसको फ्री कोचिंग दे देंगे, हम फ्री सब्सक्रिप्शन दे देंगे, राइट? हाँ. मेडिकल मार्वेल इज सेइंग गॉम्फोसिस. गॉम्फोसिस. प्लीज पंच ऑल योर आंसर्स. रॉन्ग आंसर करो, फ्री सब्सक्रिप्शन ले लो. रॉन्ग आंसर करो, फ्री सब्सक्रिप्शन मिलेगा नीट पीजी के लिए, राइट? सत्या इज प्रपोजिंग गॉम्फोसिस. What are your other answers? Yes. I'm waiting for your answers. जरा हमको भी इंस्पिरेशन दे दो. रॉन्ग आंसर करके इंस्पिरेशन दे दो. Come on guys, punch your answers. 3 घंटे से all 50 of you remained without leaving. Wonderful. I'm so proud and so happy. Yeah, punch your answer, doctor. अरे कोई भी नहीं पंच करे, किसी को भी फ्री कोचिंग नहीं चाहिए क्या? राजकुमार सैनी सेइंग डायआर्थ्रोसिस. अच्छा, हाँ. और धर्मेंद्र सिंह सिसोडिया कह रहे गॉम्फोसिस. गॉम्फोसिस. सुनील यादव बोल रहे डायआर्थ्रोसिस. अच्छा, अभी वोटिंग चल रहा है, नो कॉन्फिडेंस मोशन चल रहा है. आपका आंसर्स क्या है देखेंगे. या सो डॉक्टर, अब सबको मिलना पड़ेगा फ्री में, राइट? आई नो यू आर ऑल प्लानिंग, यू नो माई वीकनेस, सो यू ऑल प्लान दैट. अच्छा, फ्री मिल जाएगा रॉन्ग आंसर मारे तो. Doctor, diarthrosis are typically synovial and interosseous ligament, right? Sorry, it is flattened discs are either connected by the broad flattened disc of fibrocartilage or united by interosseous ligament. Amphiarthrosis है ना? हाँ, that's the point. Anybody said D? Okay. Now, diarthrosis is known as synovial joint. These are all fibrous joints except, at least इसका आंसर दे दो, रॉन्ग आंसर दे दो, खुश हो जाएंगे. हाँ. All are fibrous joints except fibrous joints में खाली 3 बोला. So now which is not a fibrous joint आपको दिख रहा है, उसको आंसर करना पड़ेगा. Which is all are fibrous joints except, shoot your answers. Come on. 366 क्वेश्चन नंबर. फटाफट आंसर करो डॉक्टर. सत्या proposes symphysis pubis. Symphysis pubis. Rajkumar also concurs with Satya. Medical marvel is saying tibiofibular. Tibiofibular. Parkin. Angshuman. Clean bold. Medical marvel, clean bold. Right? Ha. Kush hua mogambo. So suture, tibiofibular, gomphosis, they're all examples of fibrous joint. Interosseous membrane के साथ attached होता है ना डॉक्टर, tibia and fibula. हाँ. So suture, dense connective, fibrous connective. Then syndesmosis between radius and ulna, and the gomphosis, they're all the examples of the fibrous joints. Yeah. The joint between two ends of the bone covered by a cartilage, just like one epiphyseal plate growing at two ends, is called as what? 367. अच्छा इसका आंसर फटाफट बोलो. हाँ. So, joint between two ends of the bone covered by a cartilage, just like one epiphyseal plate growing at two ends. What is this called as? Question number 367. Sesha Gopalan, I am not seeing your answers. Yeah. Question number 367. Fatafat bolo doctor. 10 p.m. ho gaya. Ha. So, Satya says synchondrosis. Synchondrosis. Okay. Any other answers? Synchondrosis. Very good. So, it is called synchondrosis. Excellent. So, typically you have the costosternal synchondrosis and a epiphyseal plate in the long bone. Then symphysis means symphysis pubis and intervertebral disc. जो है ना, that is symphysis is what you need to remember. Radio-ulnar joint is what type of joint? At least ये wrong करे तो मैं अभी मेरा त्यागपत्र दे दूंगा. ऑल इंडिया पोस्ट ग्रेजुएट डेंटल एंट्रेंस एग्जाम 2017 का गर्मा गर्म क्वेश्चन है ये. 368 अभी हम डिस्कस किए. या गिव मी वन स्ट्रॉन्ग आंसर डॉक्टर. Loud and strong answer. Radio-ulnar joint is what type of joint? Shoot your answer. Yes. Dharmendra Singh Sisodia, Satya are saying fibrous type of joint. Vivek Kumar also says fibrous type. Anna, a pivot type of joint. No doctor, radio-ulnar. Saddle and pivot में pivot type of joint. Right? हाँ. Of course. Pivot. Indrajit Kumar rightly says. So, it is a pivot joint. The radius and ulna along the vertical axis, there is a movement of supination and pronation. Now, these are all the fibrous joints except suture, gomphosis, syndesmosis. They are all the examples of fibrous joints, but not temporomandibular joint. The suture, syndesmosis and gomphosis, they are all the fibrous joints. Temporomandibular जो होता है, synovial joint है वो. It is a bicondylar joint and it is a hinge type of a ginglimo-arthrodial joint and more than one articular surface called compound joint and intracapsular disc है इसलिए complex joint. A complex compound ginglimo-arthrodial bicondylar synovial joint is the temporomandibular joint is what you have to emphatically remember. The first costochondral joint is what type of joint? Question number 370. One strong answer. Question number 370. Yes. So you should remember it is an example of synarthrosis is what you need to remember. The first chondrochondral junction. So, what are the functional classification? Diarthrosis, amphiarthrosis and synarthrosis. Synarthrosis होता है immobile joint को synarthrosis बोलते हैं. Slightly mobile is amphiarthrosis, freely mobile is diarthrosis. Synarthrosis, also called synostosis or syndesmosis. एक ही नाम होता है synarthrosis, synostosis, syndesmosis. It is a bone-to-bone union, and it begins as a joint, and there is a fibrous membrane between two bones, and it is non-movable. Fontanelles are the classical example of synarthrosis, is what you should remember. Atlantoaxial joint. What kind of joint it is between atlas and axis? It allows rotation of the head, and it is a synovial joint. That is what you need to remember. So pivot joints, they permit rotation. Example is the first intervertebral joint, that is the atlantoaxial joint. Then saddle joint is the thumb. The joint between two bony surfaces linked by a cartilage. What is it called as? It is called as synchondrosis, as what we have already discussed. A cartilaginous joint, hyaline cartilage, is called synchondrosis. The best example is the sternocostal joint. The first sternocostal joint, where the first rib meets the sternum, is an example of synchondrosis, is what you should basically remember. So that brings us to the end of the wonderful evening, doctor. Let me quickly once more advertise to all of you that Monday, forthcoming Monday, क्या date हो गया? Forthcoming Monday is 19th. Tuesday, Wednesday, Thursday. 4 days, evening, 6 p.m. to 10 p.m. We will run a marathon session, pathology. हम 40 topics, and we finish these 40 topics, totally 600 MCQs. Last 15 years of All India PG dental exam का क्वेश्चन बैंक को क्लासिफाई करके टॉपिक वाइज, बिकॉज ऑलरेडी हम पीजी मेडिकल एंट्रेंस का रिवीजन कर चुके थे. इट इज ऑलरेडी अवेलेबल इन द ऑनलाइन एमबीबीएस वीडियो लाइब्रेरी. सो लेट अस master this. Even this is also a good question bank. So since it is only 600 MCQs and a 4-day session into 4 into 4 16-hour session, those who have not joined us, we are offering this 4 days entry pass. We will do it not like a free session like today, and you can pay 1,000 rupees. Yesterday we thought it to be made 2,000, but some students requested, sir, 19 subjects hai, bahut महंगा हो जाएगा. So 1,000 rupees, live online interactive, आपका एक subject का revision हो जाएगा pathology का, and this archived video content of the live session will be made available in the onlinemmbbs.com, and you can always do the revision. So please give a call to 9000 868 356, our helpline number, and then you can pay through Paytm, PhonePe or anything, and then get the entry pass for this 4 days, 16 hours marathon revision of a crash course of 600 MCQs, 40 topics in pathology from the last 15 years question papers. So thank you very much. Tomorrow is going to be a free session. Please join at evening 6 p.m. Thank you.